As we turn our attention to the issue of psychopharmacological treatment of childhood mental disorders, it is important to recognize how the rates of diagnosis have changed over the past few decades. The rate of bipolar disorder saw a 40-fold increase between 1994 and 2003. Some have argued that this increase simply reflects better awareness of the disorder, but others point at this increase as a symptom of overdiagnosis. There has been great controversy surrounding the release of the DSM-5, the fifth revision of the Diagnostic and Statistical Manual for Mental Disorders. Bear in mind that the DSM is simply a way for clinicians to categorize clusters of symptoms. If the same patient visits two different clinicians, the clinician should be able to use a common diagnostic term to describe the patient's presenting symptomology. Thus, it provides a common language on which to base discussions. But disorders come and go. The specific symptoms that define a condition can be altered over the years, and there is little biological evidence that would support the various categorizations. With the increasing diagnoses of bipolar disorder in children, a new disorder was introduced in the DSM-5 called Disruptive Mood Dysregulation Disorder, or DMDD. The proponents for this argued that it would allow for more accurate diagnosis. Children not meeting the criteria for bipolar disorder should not be incorrectly classified as bipolar, but would gain from having this less stigmatizing diagnosis. However, the more lenient criteria for DMDD also allow for a larger proportion of children to be diagnosed. Fewer children might get diagnosed with bipolar, but more children will get diagnosed with DMDD. And what will the treatment for this condition be? One of the greatest concerns surrounding medication of children is who makes the diagnosis and recommends treatment. Too often, children are evaluated by family physicians or pediatricians, not psychiatrists or psychologists. As a result, the diagnoses may be based on limited training and frequently involve medication. There is also concern that disability payment for children with diagnosed mental disorders may act as a financial incentive for parents to have their children diagnosed. At around $700 per child, one could have some influence, particularly for low-income families. As a student told me, a mother was interested in buying an expensive phone from his store, but said she'd wait to see if her child was diagnosed with bipolar and she got disability before deciding whether to buy it. Diagnosis is one thing, but there are also concerns that disability is more readily approved when the child is taking medications for the condition. Should the people who review and rewrite the DSM have financial ties to the pharmaceutical companies, such as stocks? What about members of the FDA who review and approve pharmaceutical drugs, or members of Congress who vote on regulations affecting pharmaceutical companies? These financial conflicts of interest are a great concern for many. In the video, you saw how child psychiatrist Biederman promoted the idea of childhood bipolar disorder, a disorder that had, until then, been viewed as a disorder that was restricted to adults. In 2011, Biederman was found to have violated conflict of interest policies of Harvard Medical School and the Massachusetts General Hospital by failing to report all of the $1.6 million income he earned from pharmaceutical companies during 2000 to 2007. He had to write a letter of apology and couldn't get more money from pharmaceutical companies for a whole year. Conflicts of interest aside, what about the issue of multiple prescriptions? Side effects of one drug are treated by a second drug. Side effects of the second drug then require a third drug, and so on. So now we have a child on multiple medications for which nobody has tested the various drug interaction effects. And yet, what are the options? While behavioral treatments, counseling, and psychotherapy might seem like options to explore, Do some situations require biochemical intervention? It's easy to blame the child's behavior on bad parenting or inadequate discipline, and to chastise parents for putting their child on medication. But it's important to recognize that not all parents make this choice lightly. For many, it is a painful decision that comes after months or years of dialogue and struggle. Until we've walked in the shoes of some of these parents, it's probably wise to refrain from directing too much blame or from claiming that it's something you would never do. Jessica's statement struck me and saddened me. Taking medication makes me more calm, more like I'm supposed to be. We don't know how Jessica is supposed to be. We've never had a chance to see how she might have developed without medication. And we don't know if Jessica is supposed to be calm, or someone who would light up the world as she matured with passion and drive. Perhaps lack of treatment would have caused her to do poorly in school and would have set her up for ongoing failure. We just don't know. Most of the drugs have not been adequately tested on children and may not have FDA approval for use with children or adolescents. But doctors are not breaking the law in prescribing them. A doctor can use a drug off-label if he or she believes it's in the best interests of the patient. And in using it off-label, the doctor has to experiment with dosages, drug interactions, and be watchful of uncertain side effects. Ultimately, the child is at the mercy of the parents and the doctors. They have little say in what drugs they're administered. So what are the options? President Clinton pushed for pharmaceutical companies to do drug testing on children. A law was even passed that gave the companies a financial incentive to do so by extending their patents. And while this seems like a necessary step, one has to wonder who the children are that are exposed to these experimental drug trials. Controversy surrounds this issue. Concerns are raised over the biased inclusion of poor families at home and abroad. When antidepressants were given to adolescents, reports began to emerge about teenagers committing suicide after starting the drug. Ultimately, the FDA required the pharmaceutical companies to include a black box warning on packaging of SSRI antidepressants, indicating that the drugs increased risk for suicidal ideation, thinking about suicide, and impulsive behavior, a dangerous combination. Unfortunately, though this warning may have spurred the reduction in prescription of antidepressants, doctors moved toward prescriptions of antipsychotics that had no known efficacy for the condition. It's also important to emphasize that such drugs should not be stopped abruptly. Patients should always work out a plan with their doctor for tapering off the drug if they want to stop. The final chapter to this story is the issue of early drug treatment in children that have yet to develop bipolar. Dr. Chang at Stanford argued that once the disorder had taken hold, it's too late. It's much better to identify children who are showing early signs of the disorder and start treatment then. In doing so, you steer the brain away from developing full-blown bipolar. This is a very controversial approach, particularly because we have no way to accurately predict whether or not a child will develop bipolar disorder. If we give the drug and the child doesn't develop the disorder, have we proved the theory? What negative consequences might administering these drugs have on the developing brain? It's simply too early to tell. Whatever your position on the issue, it's an important one to think about and to keep a watchful eye on. Be aware of the conflicts and think critically about whether or not prescription treatment is the most appropriate